Hello, I'm Dr. Thomas Schuler, Chairman of the Medical and Scientific Board of the National Spine Health Foundation. We're interviewing the top spine specialists around the nation to find out what you can do to overcome your back problem or your neck problem. I'd like to welcome you to Spine Talk Cities 2020. One of the things that we'd like to talk about is minimally invasive surgery, and obviously this means a lot of things to different people. And so what I'd like you to do is just comment on what minimally invasive surgery means to you, what it should mean to the public.
People should think of minimally invasive surgery as trying to attain everything we can attain with classic surgical techniques, but doing it with less destruction of normal tissues and normal anatomy for people. And if we can do that, we can often get them back out of the hospital quicker, sometimes the same day, and back to doing the things they love to do much quicker. But it has to be able to achieve the same goals with less risk, or at least the same risk, if not less risk, than our open historical procedures that are then the gold standard that we're changing from.
Minimally invasive surgery, very simply put, is making smaller incisions, but still doing the same surgery that we would do if we did it in an open fashion. Minimally invasive means minimal damage to the normal tissues. And certainly when I think back 30 years ago, when I first started in this field, we used to make very large incisions, and now our incisions are smaller and smaller. We've learned newer techniques, and yes, some of them are Band-Aid techniques. Person out there should not be fooled that just because it's minimally invasive doesn't mean it's better. We're still doing the same operation. It's just that we are not violating the normal tissue planes. We're trying to preserve the normal anatomy and allow that patient to recover faster. But ultimately, we're doing exactly the same operation. It's just that now many of these operations can be performed on an outpatient basis. So it's not necessarily the size of the incision, it's the tissue damage that we're avoiding when we do minimally invasive surgery. And for example, I do a lot of lumbar disc replacement, and we make a minimally invasive incision in the front of the stomach. And when I describe it to my patients, like anybody out there, I say we make an incision in the front of your stomach and we dissect inside the abdominal wall. It sounds like we're doing a lot of damage, but we're just following normal tissue planes. So that's minimally invasive. But now we do minimally invasive fusions in the lumbar spine, and patients go home the same day. So the advancements are tremendous, but I would just warn the people out there to not be lulled by websites where they're a doctor professing that he has the best minimally invasive technique, because there's a lot of stuff out there that just is not true.
Minimally invasive surgery and techniques are ways that surgeons can minimize both the incisions and minimize the tissue handling and injury that happens during any kind of surgery. As you imagine with spine surgery, it is a structural problem a lot of the times. And so that does require opening up the body and opening up for surgery. But over the years and decades, as surgeons have advanced through both techniques and technologies, there are now safer, better, faster ways to do the same thing through smaller incisions, smaller surgeries, and different techniques to still accomplish the same goal of getting you better, but minimizing the risk and accelerating the recovery. And I think for me, that really is what minimally invasive surgery is.
From my perspective, it's really any sort of technique that minimizes soft tissue damage and entry into the spine. So most of our procedures are aimed at accomplishing a few goals, and one is neural decompression, the other is potentially fusion. And in my opinion, minimally invasive techniques are techniques that accomplish those same goals, but less soft tissue disruption. Right. So, I think the majority of us strive to introduce these techniques in our practice and apply them to patients and offer them to patients because we feel that we get as good, if not better, outcome. In my practice or in my hands, what I've really noticed the biggest difference is patients recover quicker, right? So it's the kind of recovery kinetics behind it to where, instead of taking 2-3 months to get back to work and stay in the hospital a lot longer, we're getting patients up quicker, we're getting them back to work quicker, and we're getting back to a lifestyle that they're happy with much quicker.
And I think the appeal of minimally invasive surgery to patients is that there's going to be less pain, quicker recovery. But for patients, it's important to know that not every minimally invasive surgery is the right option for every single problem that a patient may have. And so on one hand, it's great to have a lot of options. On the other hand, from a patient's perspective, it can make it a very complicated scenario where you're trying to reconcile a lot of different, perhaps, opinions from different surgeons, and then you factor in what you can find on the internet, and then trying to figure out whether or not a particular procedure is even right for you.
If you are talking about anterior cervical procedures, I would say almost all surgeons, whether orthopedic surgeons or neurosurgeons, we do less invasive or minimally invasive procedures where we make a skin incision and then use the body's own natural tissue planes to expose the spine. Once we expose the spine, then we do the same type of surgery, whether it's decompressing, fusing, or replacing in the cervical spine. Now, in the thoracic or the lumbar spine, when we make an incision in the back, or what we call posteriorly, the group of surgeons that do open procedures tend to do midline or right in the middle procedures and remove the muscle from the spine in order to expose the pathologic area where they can actually then do surgery, versus minimally invasive or MIS surgeons tend to make incisions to one side or the other. Those are called paramedian incisions in medical terms. And instead of taking the origin and insertion of the muscles, we tend to go through the muscle belly. And at first thought, some people would say, well, that's more traumatic to the muscle. But in fact, it's less traumatic because we're going through the normal tissue planes of the muscle and are not taking away their nerve supply, their blood supply, or their origin and insertion on the bone.
If you're using these technologies as part of spine surgery, does that mean the surgeon's not doing the surgery? Does that mean now I have some computer system doing my surgery? Tell me a little bit about how that works and maybe what the safety mechanisms there are there, if I'm a little unsure about that.
I would say that especially for minimally invasive surgery, the use of robotics and a robotics platform is essentially bringing in technology that has been around for quite some time. So if you think about how your car is built, or how the spaceships are built, or how your clothes are made, when you visit these factories, there are robotic arms that are carrying out very delicate and highly precise tasks. Now, when you come to medicine in the human body, there's a much greater, bar to bring in these types of technologies for the safety of you and other patients and people in general. But that bar is now able to be met. And especially when you think about minimally invasive spine surgery, prior to robotics, there were technologies like X-ray machines and computer-guided navigation to allow us to go down smaller incisions in precise and accurate ways. With spinal robotics, when you marry the abilities of computer algorithms and predictive planning in a very precise instrument, that improves our ability to offer minimally invasive surgery in those same realms with increased precision, accuracy, and safety. And the analogy I always use is sort of like when you're driving your car, you're getting from A to B, and usually you get to A to B fine. But when you have safety technologies like automatic braking and blind spot monitoring, and then active cruise control, and now on some cars you have autopilot and semi-autonomous tasks, you still get from A to B, but with each added layer of technology, you get there more safely and accurately. And I think robotics is the same in the same way in adding that technology, not just for the sake of technology, but for patient safety and patient care.
Even the scoliosis deformities, there are some surgeons that are doing minimally invasive placement of the screws and the rods and even the fusion. So what used to be a huge incision in the back turns out not to be quite as bad as what it used to be. And the trend is going to continue. And I think the trend for minimally invasive with robotics and with navigation, robotics meaning that you'll still have a surgeon in the room, but you'll have the assistance of these very, very stable arms. And maybe someday the surgeon will sit behind a control panel and do the minimally invasive surgery, because we'll have better optics, we'll have better visualization, and all these things are coming down the line. So it's very, very exciting.
So when we talk about spinal robotics, it's helpful to think of it as an assistive technology. So your surgeon is still there, your surgeon is controlling everything in the room. The robotic arm is another very sophisticated tool. So the two analogies I can think of is, instead of using a screwdriver, your surgeon is using either a power drill or a robotic drill. Another analogy is, say, a pilot in an airplane. So instead of flying a Cessna, right, where they're actively doing everything, say pilots that are flying your Boeing, 767s. So the pilot is still there. The pilot is aware of everything, but there are all these assistive technologies that allow the pilot to get you to where you're going. Spinal robotics is no different. It's special because you actually have an arm, so it's not just more computerized software. It's not just more this nebulous technology. The technology is actually wrapped up in a special tool, but your surgeon is still controlling everything, making all of the decisions, and needless to say, there the entire time.
What does the future hold? And you hear so many stories about somebody who had a spine surgery and it didn't do what they had hoped it would, or they had a spine surgery and then they needed to have another spine surgery sometime down the road. What do you counsel patients when they're asking these kind of questions about now and the future, and how do you help them to understand and deal with some of these fears that are so natural?
Yes, if you wait 2 to 5 years, there will probably be better technologies that may make things a little bit more safe, a little bit faster, your incisions are smaller. But if you wait that amount of time, that's 2 to 5 years of your life that you're losing, that you could actually recover from surgery and then gain your life back. So the movement of technology is always to make things better, but by no means is what we have poor. What we have is excellent today. The only sense in waiting is if you want to hold off on surgery, which is very reasonable, or if you're happy with your life as it is and you don't want surgery, which is perfectly fine too.
And what I tell the patients is that it comes down to quality of life. If they're miserable today and cannot do the things they like to do, and they always say, well, Dr. Dyer, what would you do? And I tell them, I say, if I couldn't sit here in front of you and sit comfortably and take your history and examine you, and if I couldn't stand outside the room and dictate, and if I couldn't stand in surgery all day long, I would have the surgery. On the other hand, if your quality of life is not so severe, then you shouldn't have the surgery. But I do tell them that if they say they're waiting for technology, I say, look, things are continuing to advance. Even if you have a fusion and something breaks down in the future, and it's not 100%, I quoted the number 10 to 15%. Advancing technology, for example, will have more minimally invasive ways of going into the disc, maybe doing a fusion, maybe we'll implant some device through very tiny incisions that can maintain the motion. So I'm a great believer in science and technology, and the brilliance really of our researchers and our doctors that are in the field, because I see changes every single year.
I think if the patient has a progressive neurological deficit of any kind, no, you shouldn't wait. And what I mean specifically by that is, if weakness is getting worse, or if your balance is getting worse, or something that is not is behaving in a manner that we can wait and see kind of thing, then I would say definitely not. And so if a patient's in pain and they're waiting for a new advancement in some sort of technology to do it through even a smaller incision, I think we're almost there now, and I don't think things are going to change materially over the next, say, 5 years.
There are certain diseases within spine where a patient doesn't need surgery or doesn't end up needing surgery. But if they've failed all those appropriate non-operative treatments that we always try to do, and they're in terrible pain, it's silly to wait a decade, because we have techniques now that are, I think, so good that to sit and suffer and wait, the human cost of what spinal nerve pain and pain that comes from spinal disease is so severe that to wait to look for something in the future that may or may not be better than what we have today, I really don't endorse that way of thinking. I don't endorse rushing to surgery if you haven't had other appropriate treatments, but I don't endorse waiting for the next great thing to come along.
Right now, if it's needed and it's going to improve your quality of life and get you back to doing things you enjoy doing, I would say go for it.
If someone came to me and said, well, I don't want a fusion now, but in 5 years, the technology is going to be so far superior, then I'll do it then. The first thing I would say is that probably we will do very similar techniques in 3 or 5 or even 10 years as we're doing now. Now, there's some nuanced differences. In other words, for instance, we've done a really good job, and industry has done a really good job doing cervical disc replacements. That technology is here to stay. Lumbar disc replacements, we had that technology, worked very well for some people, but probably still needs some additional evolution before it comes back into vogue. But with decompression and fusion techniques, kind of the bread and butter of what we do for patients to help them, I don't think that 3 or 5 years is going to make a big difference. And what I tell patients is, if it is bad enough now to affect your quality of life, and you've tried all the non-surgical things, in other words, you've tried injections, you've tried therapies, you've tried restorative care, and it's no longer working for you, life is short. Why do you want to be miserable if we have a very good surgical solution? So if individuals have nerve pain and potentially motor deficits, that's where spine surgeons come in, and we can save the day for patients, which otherwise, if they just wait, it becomes much less likely for us to be able to solve surgically that problem. So I've had many patients come in that have had a foot drop for a year and come in and say, please fix me. And I'm like, well, I don't think we're ever going to get your function back, but if we did this at month 1 or 2 or 3, you would have a much better likelihood of an outcome. We've proven very nicely that early treatment for people that have significant neurologic deficits and pain, we do much better.
Oftentimes the thought is in trying to figure out which levels to operate on. The thought can also be done on whether to fuse, which is to place instrumentation, or not fuse, whether to do replacement and motion sparing procedures versus not. Again, the thought is there. Not everyone will be a good candidate. So, at the end of the day, it's true that motion preservation and not fusing is always better in general, but sometimes patients come and they're just not good candidates because of what they have. But there are things that surgeons can do to help prevent things down the line, and that starts getting into a lot of technical considerations that oftentimes for my own patients I will get into, especially if they're interested.
But how does a patient go about choosing the best spine practice or the right spine surgeon outside of what type of technology they may or may not use during their care?
There's a few factors. One, what's the doctor's experience? How many of what have they done? I'm a believer in specialization, but if I'm a patient, there's a lot of websites and there's a lot of rating agencies, and they can be useful, but I would caution a few things about it. One, sometimes people who just didn't connect with the doctor or had bad interaction will get on because they're angry, not even a bad result, just not a good interaction, and say, this doctor didn't care about me, blah, blah, blah. That's one caution. And sometimes there's different personalities. People who had a great result and said they're busy. They're not going to the rating agency. So I would just say they can be useful, but with caution. I would combine that kind of thing to word of mouth. But to me, the most important thing is when the patient goes to the doctor, they ask the questions. How many of these have you done? If I was your wife, mother, brother, sister, what would you do? What would you tell me to do? Please look me in the eye and tell me what I should do, given feeling like that. And three, are they comfortable with that surgeon?
You know, I think your surgeon that you're looking for needs to have several qualities. One, they need to be technically good, which is very hard to vet sometimes from a patient perspective, right? They need to have good bedside manner and make sure you're comfortable and be able to answer appropriate questions.
Probably one of the first few things that you can do is, again, sort of check online. That's sort of a very large resource for everybody. I would say when you look up your surgeon online, there will be good things about most people, which is a good thing. If a physician is a part of a university, then you can look up their bio and sort of see how they're set up there. And oftentimes the university itself will have their own rating system. If the physician is not a part of a university, then generally, if they're well-known enough or established enough, which is always a good thing, then the community themselves will have come together and commented on this physician. I would say that although it's not 100%, especially for folks who are newer, if you don't find anything, that doesn't necessarily mean a bad thing, but it probably won't allay any fears or anxieties that you have, unfortunately. Out of habit, most people just try not to look for the bad things, obviously lawsuits or, the real red flags. At the end of the day, probably the most important thing that a patient can find, and unfortunately you can only determine this if you meet the surgeon, is just someone who you get the sense that they have a direct investment in you.
The first thing I always tell people is to ask around a little bit. In other words, ask your neighbors, your friends, if you go to church, churchgoers, who they've had operate on them. Spine pathology is very common. Most individuals have someone that they do know that has had spine surgery. So word of mouth is one very good option. Another is if you know any healthcare professionals, that's critically important. So for instance, even at the hospital that I work at, if my fiance needs some OBGYN care, I am going to speak with the nurses that are OBGYN nurses to see which of these physicians are very reputable and which do the best job doing certain technologies. So that's another. I think some of the magazines are reputable, like Top Docs, because Top Docs uses other physicians to expect for them to submit who they think are the best physicians in the area. I would always be a little wary of getting most of your information from the internet in terms of places like, and I don't mean to insult anyone, but Health Grades, because many of those are patient-based platforms. In other words, you could maybe not come across as the nicest surgeon or have long wait times, and you could get detrimental grades on some of these websites versus you are a very competent surgeon. So just use multiple resources in determining who is the best. One other thing is, don't necessarily as a patient think that the chief of the university hospital is the best surgeon or someone that has the most publications. Don't necessarily run to the university setting or to someone that's written the most articles on a certain technique. Doesn't mean they're the best, because peer-reviewed does not mean surgeon, clinically reviewed. It can be a very different thing, and it can be a very big disconnect.
Really pick wisely and understand the disease. There's lots of resources that didn't used to exist to understand what the right way to go forward is.
There are really talented surgeons and there are surgeons that are not. Get as many opinions as you think you need. I think knowledge is power. And we know that there's a lot of heterogeneity in terms of how surgeons and non-surgeon spine providers treat patients, whether it's injections or surgery. That disparity exists. I think that looking online reviews are helpful, but they are not the holy grail. And you have to be careful in terms of what you find on patient reviews. But oftentimes, if you go through enough reviews and if you see themes regarding one surgeon where there's a consistent positive review, don't just look at the stars, but look at the narratives that patients write about specific surgeons. Do your due diligence. it really comes down also beyond all of that. How do you feel with your relationship with that particular surgeon? Did they take the time with you? Ask them important questions. How many of these have you done? And I think if a surgeon is forthright and he's experienced and he's comfortable with his own skill set, he or she will tell you, I've done 100 of these. I feel very comfortable. I know that I'm going to be able to predict this type of result in you. If, on the other hand, there's any yellow flags that a patient gets in their own mind about the interaction with a surgeon, listen to your gut and get a second or third opinion. I think it's a healthy thing to do.
Now, I'm afraid about upsetting my doctor. Doesn't getting a second opinion perhaps mean I don't trust them, or I don't respect their opinion, or is that insulting to you if a patient were to get second opinions and things when you're caring for them?
When somebody's undergoing spine surgery, just like we discussed prior, that it's a scary event. I mean, it's a big deal for any patient to go through, any family to go through, and everybody knows somebody that has had a spine procedure or spine surgery and not necessarily the best results. And so there's multiple different paintbrushes. There's different ways to paint the picture. And because somebody else had a bad outcome doesn't necessarily mean you're going to. And so make sure you get all your information right. I think as innovation pushes forward, we're finding that we could deliver as good, if not better, results through these minimally invasive techniques and the use of robotic guidance, et cetera. And so what I would have to say to the patients out there is, if you have to have a fusion or have to have a spine surgery, find the right surgeon. Make sure you communicate well with them, and your outcome is going to be good for the most part. We wouldn't be in business doing this on a day-to-day basis if we weren't delivering good results. And so there's hope out there, right? And I have a very young, active group of patients, some of which are in my gym or participate in other activities with me, and they're back to lifestyle that they enjoy, right? I would urge the patients to seek opinions and find the right surgeon, and you're going to get a good outcome.
It is so much different today. And in the past, patients would say, oh, my friend had back surgery, he's doing terrible. I think the surgeons today are much better educated. We understand the indications much better. We have much better tools than what we had in the past. And the days of, I've had one operation, another operation, and I'm not any better. The bottom line is that the quality of the spine surgeon today is so much better than when I finished compared to the folks that were out there. Now, granted, they're not all great surgeons. It's like the bell curve. We have our great doctors. You have the ones in the middle that are really good docs, and then you have some folks at the far end. But don't deprive yourself of living a miserable life if you have something that's treatable by spine surgery. And then the other thing I'll say, get a second opinion. If you get one opinion that sounds crazy, get a second opinion.
But if you have two surgeons that similarly agree on the technique to be used, that is comforting for patients as well. And then ultimately, patients have to be comfortable with their physicians. If you are not 100% comfortable with your surgeon, go somewhere else. There's plenty of us out there. And you have to go into that day when you're about to have surgery to have 100% confidence in your surgeon.
I always encourage my patients for other opinions, right? So there's so much variability in spine. It's good for them to hear it from somebody else. So seek other opinions, ask around, check out what's on the web. Don't trust everything that's on the web, but all those are good resources, and they should come together to make you feel good about your choice.
Getting a second opinion to me is peace of mind. And personally, I can tell you that I have and will never be offended if someone says, you know what, I'm going to ask someone else. Because at the end of the day, all I care about is that you get better and you find someone that you're comfortable with. And if that's not me, then that's okay. Because in what we do and what we care about, which is spine problems and spine surgery, my primary priority is just that you find a decision that you're comfortable with, whether that's surgery or no surgery. And if it ends up being a surgical intervention, that you find a surgeon that you're happy with and that you get better. And that's all that I care about.
So with the innovation that we're seeing, sometimes we innovate out in front of insurance payments. And so what do you say about if a service or product is not covered by insurance because they call it, quote, experimental. How do you tell a patient to address that?
If the physician and the patient really believe that a particular technique or approach is going to be the best for them in the short and long term, then it's worth a conversation with payers. Now, at the end of the day, when a peer-to-peer happens, so when a physician talks to a payer, it may or may not be successful, but at the end of the day, we're only as strong as that conversation and what the payer is ultimately going to decide, and we just don't have overriding capability, and so it really, the financial implications become borne out by the patient, which is not necessarily fair. But I think there's some things that can be done as long as it's the right thing for the patient. The doctors can go the extra mile and talk to the insurance companies and present a cogent case of why a particular approach is necessary to a particular patient.
First of all, it's the squeaky wheel. You have to complain to the insurance, and oftentimes I will write a letter of medical necessity for them. And I'll go through a letter. We sort of have a form now that says, look, this is a 29-year-old. He's had 3 previous discectomies. If you do a fusion on him, he has this chance of getting, and I go through all the reasons why he should have a certain operation. And the other thing that is helpful, sometimes the insurance that they have, depending on the company they work for, the company may be self-insured, which means that they might have Blue Cross Blue Shield, but the insurance company, for example, may only be the administrator. And then you can take it to the HR folks of the particular company and get it overridden. So we tell them to be the squeaky wheel. We'll write the letters. If they're self-insured, we have a good chance of getting the surgery approved, because if you just have to convince the HR folks that this employee's best option is for this operation. And the other thing, sometimes it is absolutely ridiculous. Like recently, I had a patient that was told, I think a cervical disc was experimental, disc replacement that is. And I said, that is absolutely ridiculous. I said, you need to call them up right now. You need to call your senator or your representative. You need to write a letter to the insurance commissioner, and you can tell the insurance company you're doing that, and I assure you that they will approve it. So that's some of our strategy. It's frustrating. And then sometimes they just won't pay for it, and then the patient gets stuck paying out of pocket. And a lot of them can, and a lot of them can't. And then they have to decide if that's what they want to do.
My goodness, if something's good enough to get FDA approval, which you and I both know is a pretty high hurdle, the highest hurdle in the world, it should be good enough for an insurance company to pay for the patient. That to me is the most irking thing, that the patient's paid money to be able to get care and then can't get it. So the advice is really advocate. Insurance companies may not listen to a doctor, but they will listen to their insured. And if they make enough noise to the insurance company, they can get approval for something.
If the government decides that somebody over 65 shouldn't get a treatment paid for, a lot of times insurance companies follow that, and that's a 20-year-old that would be fantastic for that procedure. So I think it's going to get worse. And I think the way to go around it is to find centers that are pushing the envelope, right? And have a discussion with them, right? So sit down and talk through the risk benefits and what the alternatives to treatment are and what the benefit of this new uncovered treatment is. And so, I don't think everybody should jump on the train to do a lot of procedures where there's not great evidence. But if there's good evidence and there's good results, but insurance doesn't cover it, I think there's creative ways that patients could all figure out, or we could help deliver this type of care to those patients.
Just because it is not FDA approved does not mean it's not experimental. And so we've gone to the insurance companies and really pushed very hard to get many of these technologies, which they thought were fringe technologies, but they're not. They're actually tried and true technologies that we use all the time. So for the most part, with a really good dialogue with insurance companies, you can educate them and you can get things covered. Now, there are still cases that they're completely resistant on. And then for those people that have the financial means, we have a way of providing that care at a discounted rate in comparison to paying 100% out of pocket. But in my center, that is not very common. But I know other surgeons around the country are doing surgery or procedures that are not covered, but still they truly believe in. And if people, the patients, have the resource, that's absolutely their right to be able to do that. And the insurance companies or no one can say you don't have the right to do that.
If your problem is bad enough that it's impairing the quality of your life, that you can't do what you need to do, it's critical to stay active, to stay healthy, or you're going to die of a heart attack, or you're going to have some other problem, or just not have an appropriate quality life.
A constant message weekly to my patients of all ages really is to do everything you can to habitualize physical activity, specifically exercise. You know, we all have our habits. I have my own. I like my coffee. I'll spend 10 minutes a day making it in the morning and enjoying it. But I also like exercise. And I'm a very strong believer that exercise is important, and specifically exercises that work at the core, the abdomen, the back. Stretching the legs is incredibly important. But not necessarily, and I'm not saying everybody needs to go to physical therapy, because physical therapy only lasts maybe 6 weeks to 12 weeks tops. But it's really important for patients to take ownership of the life that they're living and make sure that they're doing the things today that's going to get them to where they need to be later. But also, patients come to you and they're in pain, and you say, yes, we have a solution surgically or not. But I also can tell you that your pain will be mitigated to a large degree in the longer term. You will have less spinal problems. Your spine will degenerate at a slower rate if you lose weight, if you stop smoking, if you exercise, to some degree daily. And those are the sorts of things that I think will lead to a healthier spine and really, and people and patients always chuckle. I mean, the last person you want to see is a person like me. Even though I love seeing you in person, you're better off if you don't have to come to the Cleveland Clinic to see me. But there are ways, but trying to get that, instilled into a patient if they're not used to doing it in a 25-minute or 45-minute session is really difficult. But we do everything we can in our department to make sure that we message, that we deliver we get them started on physical therapy, and we impress upon them the need to do that. But if I can make everybody exercise and lose weight and be the weight that they were when they were 18 to 20 years old, because that's what you probably should be. But paradoxically, we see the exact opposite. And so you would think, well, a patient can carry the most weight when they're young, right? Because their spines and their skeleton are completely healthy. But the exact opposite is true. And so we move through life, we put on more weight, and it really is borne out by the spine. And we see advanced degeneration in patients who carry extra weight. And so if I could do anything in my career, it'd be impress upon enough patients to change that.
But I can tell you regular exercise is extraordinarily important. Keeping your core strong with either physical therapy or on your own. I think eating healthy is critically important. So many of the disease states that we deal with are self-induced. And so the better we can be to our bodies, the less likely, in some cases, there's genetics though, so things are very multifactorial, but I think it's just caring for yourself and have a good balance in life.
But you can really maximize your spinal health by staying in great cardiovascular shape, good nutrition, and really good fitness. It makes a huge difference. You will still be irked by your genetics, but you will have less incidence of back pain. When you have it, it'll be less severe, or neck pain, and you'll protect yourself. So I always say to patients, you're really, really well served by being in the best shape you can.
Another question, with so many advancements in technologies, and we're always reading about all these things, if I'm a patient who's suffering with a spinal problem, how do I decide, is it the right time to treat? Is this something I should be waiting for a better technology to come in the future? How do I make those decisions and stay up to speed on what the best thing is? As there's a lot of information out there.
People come and say, oh, my neighbor said I should never get spine surgery because no one does well with spine surgery. I said, well, actually, that's not true. We're in a world where if you pick the right diagnosis and the right treatment for the right diagnosis, we achieve over 90% of patients doing very well with a very low need for a revision rate. Because that's the other thing people come in or said, well, isn't it true that every time if you have spine surgery, you're going to need to have another spine surgery? I said, well, that's not actually true either. But the genetics you come to me with, meaning your mom and dad, whatever they gave you, you're going to leave the operation with. And if there's a history of a lot of arthritis in your family and all these things, you may get it at another level. Just like a person who has a knee replacement and has a knee replacement on their right knee, when they come back a year later and they need a left knee replacement, or 2 years later, they don't blame their right knee replacement for their left knee replacement. But if they have a herniated disc at C6, 7, and they get a beautiful result from treatment of that herniated disc, when a year later or 2 years later, their C5, 6 disc herniates, it is not really the fault of that 6, 7 operation, but it always seems to get blamed for it. And that's just another common misconception within spine surgery that's loomed over us, I think.
Sometimes people with very large deformities of the spine or scoliosis conditions do require open surgery, which is essentially a big, long incision in the middle of the back, dissecting and exposing all of the bone and doing all of those types of bone cuts in an open fashion. There are some people where the conditions are just too great despite our technological advances. Other types of open surgery are if you have some sort of tumor. So certain tumors of the spine, or unfortunately cancers of the spine, a lot of those just have to be removed. And although minimally invasive techniques have allowed some of those to be treated through smaller incisions, at the end of the day, if the goal is to get the tumor out, then sometimes an open surgery is just the best overall for the patient and for you.
If the surgeon feels that a fusion is appropriate because the spine is unstable or there's a lot of degeneration, that's when we consider doing fusions. And so there's various techniques of making an incision in the front and doing this procedure called a retroperitoneal exposure. But then there's laterally based procedures, and then there's posteriorly based procedures. But one of the reasons why you take the disc out itself is that increases your overall surface area to do a fusion. In other words, to get that segment solid. But then also the advantage of doing this technique, which is called a transforaminal lumbar interbody fusion, is you can restore the height of the disc to its normal non-degenerative height. You can also reduce a slip called a spondylolisthesis. So there's various reasons why we do that technique. And most surgeons now are doing T-lifts very, very commonly because they are kind of, I believe, the workhorse of treating many conditions in the lumbar spine.
When there was trauma in the cervical spine, when I trained with Henry Bowman, we just had wires. Well, now you have pedicle screws, you have translaminar screws, you have facet screws. And for the public, these are just different structures of the back of the spine, but it allows us to put screws into these different elements to hold the bones together while they heal. Whereas before, we used to put patients in a halo, which is a metal ring around their head with pins in the front and the back. Now we can take the most complex fractures, we can limit the number of areas that we fuse. For example, in some of the fractures, we would have to fuse from the back of the skull down to the mid portion of the cervical spine. And that is a very debilitating fusion because you lose your rotation and a lot of bending up and down. Now, with these special techniques, we can just fuse, for example, the upper two segments together rather than doing from the skull down to, say, the C3 level. So tremendous advances in the internal fixation and stabilization of the spine, again, which all translates to minimally invasive surgery and less destruction of the normal tissues.
Say someone has a herniated disc and needs a surgery, and they've already had a surgery for it. So they herniated their disc, they have leg pain, someone did a microdiscectomy, removed the disc, and they felt great for 6 months. And now they're coming back in and the disc has come out again. When you look at the literature, the literature suggests that even if you were to go in with a small surgery and remove the disc, there is a significant number, depending on where you read, anywhere from 15 to 35%, who will need a third surgery afterwards. And so at this point, you're sort of at equipoise. And do you do the small surgery, which is going back in, taking out that disc again? Or do you go for the definitive surgery, which is a fusion? You take out the entirety of the disc, you put in a cage, you put in the screws, rods, and it sounds a lot bigger and the recovery is a lot longer. In my personal view, there's no right answer, and it really depends on the risk tolerance of you as the patient. There are some people who would rather go for the small surgery. They can sleep at night, and if they have to come back in 6 months with a fusion, then they were happy with that gamble. And there are other people who, the first time failed, let's be definitive. I'm happy with either way, because in this way, it's a relationship and contract that I have with the patient. I typically am not very patriarchal when it comes to these. If they ask me what I would do, then I would tell them. In this case, personally, I would probably go for the fusion up front, but I also qualify by saying that I'm very risk tolerant and I'm very definitive. And it goes to show my belief in these procedures, but it also goes to show that that's my spectrum on my direction. So I'm there to help people make their decisions. And if at the end they really don't know, then I'll give them sort of an opinion in that way. So if you have a herniated disc and you get leg pain, that's typically where you present to, say, your primary doctor or your ER and are told that you likely have a herniated disc. If you get an MRI, you can get confirmation. But the pathway for a herniated disc, the condition is not dangerous, right? It's painful for sure, because it's nerve pain, but it's not dangerous. The spine isn't going to fall apart. The majority of the time, the nerves are fine. And so in the majority of cases, there's time to pursue anything that can relieve the pain. A lot of the times it's the pressure, and a lot more of the times it's just the irritation and inflammation of the nerves themselves. So that's why a lot of the initial non-surgical treatments, such as therapy, massage, traction, chiropractic manipulation, all of those things aim to increase the flexibility of the spine, reduce the irritation and inflammation to make you feel better. And if you feel better, that's all that matters. When you get into things like injections and surgery, that's where things haven't worked. And thankfully, that is a smaller percentage of the population. So, chances are, if you're looking at this video, if you're looking at it online, over 9 out of 10 times, you will be fine. But for that 1 out of 10, less than 1 out of 10, this is where a lot of the information becomes more pertinent, especially if you're talking about surgery.
Doing a less invasive procedure, particularly through a tube, whether you're going to add a fusion to it or not, it really relies on being able to see normal anatomy and navigating off of that normal anatomy during surgery with what you're seeing and what you're feeling on the spine. And when there's a lot of scar tissue, it becomes a little bit more problematic. But for simple things of the spine that cause potentially big problems for a patient, for example, foraminal stenosis, which is a pinched nerve in the lumbar spine, oftentimes that can be treated very successfully through a small incision, whether it's through an endoscope, which is a fantastic option for many patients at levels above L5S1, so L2, 3, 3, 4, 4, 5 are pretty good options if the patient's got a nerve pinched as it exits the spinal column. On the other hand, less invasive options are pretty good for focal, meaning 1, maybe or 2 level spinal stenosis, which is causing unilateral or left or right sided symptoms, and certain cases of 1 or 2 level stenosis, which is causing bilateral or both sides being involved in terms of the pain, can be treated through a less invasive option. But when you're talking about big deformity surgery or tumor surgery or infection, those sorts of things should be treated with a traditional open approach.
Many surgeons say they're minimally invasive, but they're also minimally effective. In other words, they're not treating the pathology just like you and I would do with an open procedure. I can tell you, when I do a minimally invasive procedure, I expect the exact same surgical outcome at the time of completion of the surgery. In other words, get the job done, right? If they have a disc problem, address the disc problem. If they have a degenerative process where they need a fusion, address that. So it should look exactly the same radiographically when you're done. The real only difference is that they have less of a surgical trauma, which then leads at least potentially to better outcomes, less blood loss, less infection risk, those type of things. I'm at a training center, so I've been training residents and fellows, more recently fellows, for the last 20 years. And I can tell you that that is what I teach all of the fellows. If you do not think as a surgeon you can do equally as good of a job doing it MIS or minimally invasive, you should not be doing minimally invasive surgery.
There's been a lot of research, comparative research, where they studied patients who've had a less invasive approach and compared them to in the same study to a different patient population that had a traditional approach. So we call that a comparative study. And they've done it for decompression surgery, and they've done it for fusion surgery, for 1 and 2 level fusion surgery. And what the results show that for decompression surgery and for fusion surgery, the results in the short term appear to be in favor of a less invasive option. But in a longer term, when we look at the things that are meaningful and how we measure those, and we use patient-reported outcomes. So those are the tablets and those are the questionnaires that patients fill out before and after their procedure at various time points after the surgery. And so, but in the long term, most, not all, but most of the studies demonstrate that there's no definable difference in terms of how a patient is perceiving their outcomes. So that would say that despite the apparent short-term benefit, again, less narcotics, shorter hospital stay, et cetera, in the short term, those differences are not as obvious. They don't exist at 1 year or 2 years.
But for the most part, at least in adult deformity, at least large deformities, I think there's still a substantial role for open surgery, so maximally invasive type surgery.
First of all, the skin incisions tend to be smaller. And so when you do these incisions on either side through the muscle belly, you can directly focus your surgical technique on the area of the problem, or what we call the pathology. Versus if you make midline incisions, you have to expose more of the muscle off of the spine. And when you retract that muscle from the spine, it does not have its adequate blood supply for a period of time. So blood supply is very, very critical to muscle health. So if you lose blood supply for 2 or 3 hours, it tends to not recover as well. And we've done many studies looking at post-operative MRIs, which is probably one of the easiest ways of looking at the health of muscles. And if we make larger midline incisions, that muscle tends to be much more damaged than if we do the smaller procedures where we do the side to side or paramedian exposures.
We've come light years in the past 2 decades. Spinal healthcare was horribly archaic, which is why so many people had fear and still have fear. Today it's inappropriate. And in fact, what we know from the research that's out there is that the quality of people's lives has improved more from spinal surgery than it is actually from hip replacement or knee replacement surgery, which everybody accepts as a game changer. And so we know that it works. We know the technology has evolved so much and is so powerful that if you have a problem that, as you said, you can't live with or can't have the quality of life, then the technology today is amazing. But if you can live with it and you can exercise out of it, then waiting 5-10 years is always desirable, assuming you're not having a nerve problem or a way that impairs the quality of your life so that you have a heart attack because you can't exercise. And so, I mean, that's kind of how I look at it.
How can we do better? How can we do better for the patients? Started leading to ways that we could apply the techniques we were doing open to less invasive. And then, once we started doing things through tubes and ports and scopes, we needed ways to make sure that if we had to do a fusion, we could get the fusion to heal. So we needed biological things. We needed an increase in accuracy. It led to the development of navigation, of robots. which allow all these things to come together so that we can do things without cutting the skin wide open. We can achieve accuracy in placing the instruments we need to place or doing the work we need to do at the right place at the right time, and getting patients better quicker because of all those things and having less complications, less infection, less nerve problems, less revision surgery potentially. I've worked for a long time back starting in Philadelphia and now on basic science research to understand that genetics of what programs somebody's disc to degenerate and could we reverse that genetics. And I really feel like we're getting closer. We have mouse models of aging and are really starting to understand what causes the discs, the molecular basis of that degeneration. And we have some experience, albeit in mice, where we can reverse that degeneration. But there's two parts of it. The genetics that cause the degeneration, and everybody as they age, almost without fail, if we look at it, and you look at MRIs and everything, everybody's discs will degenerate. Just like their hair will turn gray or they'll become bald. As a part of aging, everybody's discs will degenerate. But interestingly, not every one of those degenerated discs will be painful. But sometimes, as you and I know, they're horrifically painful. And that part we don't understand. Which discs will degenerate and become painful? And if we could really unlock that and predict that and block it, that if we can both not only predict which discs are going to degenerate, but degenerate and become painful and stop it, game over. I mean, it'll put us surgeons potentially out of business, but it would be for a great cause.
I think the next big advancement that'll really catapult our ability to treat different pathologies in an even more minimally invasive manner would probably be a discovery in biologics, that will allow us to achieve fusion more predictably with less of a surgery. We have certain biologics that that's one of the things that we've really evolved over the past, 20 years, in what we can apply to the spine to get it to fuse. But I think there will be some other things, not just in the world or the realm of fusion, in terms of what we can use from a biological perspective, but what else can we achieve for disc regeneration? Whether or not that's going to be in my lifetime or my career time, I'm not sure. But I think in the 20-year time frame or so, we'll probably see some biological scaffolds and biologics that can be used to prevent disc degeneration, which is one of the culprits in pathologies of the spine.
If you had a bad hip and you went into an orthopedic surgeon today, they would not say, well, your choice is we can fuse your hip or we could do a hip replacement. So I use the same analogy for the neck as well as in the lumbar spine. Now, obviously, these structures are much more complex, and there are certain indications, which means you're a good candidate, and contraindications, which means you might have some anatomic abnormalities. You might have something that says you're not a good candidate. But if you are a good candidate, it makes sense to do something that will restore the normal function to the spine. And there have been good long-term studies, especially in the cervical spine, 10 years out now, that show that if you have a fusion, you have a 10 to 15% chance of needing a fusion at another level. Whereas if you have an artificial disc, and we're talking mainly in the neck, it's about 3 to 5% chance. The same thing occurs in the lumbar spine. And the problem is that not everybody's a candidate for an artificial disc. But it is, I think is going to be a trend in the future, and not saying that, for example, scoliosis, are we going to do artificial disc? But I think we'll change the way that we do scoliosis. For example, with the deformity where people have these crooked spines or S-shaped spines, we do fusions from, say, the upper thoracic down into the lumbar spine. And what happens is, as the patient gets older, they have problems at the level below. So I think whether it'll be a flexible rod or some type of motion preservation, gradually we're going to get there. And think about it. What we're trying to do is restore motion back. We're trying to let the patient have a more normal spine rather than to do a destructive operation. And I'm not saying that fusions are destructive, but in a way, we're taking away function in a bad segment that needs to be fixed. But if there's a way that they can have motion with an artificial disc, it's better for them.
Please consider giving to the foundation to help support this education and to carry this message of hope to all of those across America.
Spine Talks is a program produced by the National Spine Health Foundation. For more information or to make a donation, visit spinehealth.org.